So stent is a prosthesis which is placed in the trachea or bronchus of both. So when you have a tracheal thing, it will be a tracheal stent. If you have a bronchial thing, it's a bronchial stent. And if you have both, covering both, it is a Y stent. Next slide, please. And it's made of either a silicone or a metal or biodegradable metal. These are the immaterial. These are the three things. Biodegradable in India is very, very recent and nascent. So let's concentrate on silicone and metal. Next slide, next click. Metal is self-expanding metallic stent where a single woven nitinol, which is an alloy, is compressed, and it can be either uncovered, partially covered, or fully covered. Next slide. Next, please. So again, it can be a straight stent or a Y stent. There are also J stents and T stents and so on, but the most common will be a straight or a Y. Next one. So who needs a stent? A patient who needs a, tracheobronchial airway is robust because of a cartilage. So a patient needs a scaffolding to support either a weak tracheobronchial tree, wherein the cartilage is damaged, which is in tracheobronchomalacia, or a compressed due to a malignancy or any other lesion, which is an extrinsic compression, or if there is a hole in the airway. These are the three reasons why you stent. Next. So look at the indications. That can be malignancy and benign. Keep clicking. Keep clicking. Next, please. So in malignancy, Dr. Rajiv has clearly said, next. Keep clicking, please. Extrinsic, intrinsic with extrinsic component, and next, a tracheoesophageal fistula. So all three things are possible in malignancy. And benign, you can keep clicking, sir. As I said, click, just keep clicking. Next, please. So in benign, there was a post-intubation tracheal stenosis. Next. Tracheobronchomalacia. See, in tracheobronchomalacia, we don't use a stent. Yeah, you can keep clicking as I speak. So tracheobronchomalacia is as a bridge to surgery. So you put in a stent and then see if the patient is improved. And if he is improved, then you do a surgery. In tracheoesophageal fistula, especially in benign cases, it is only a bridge to surgery. It can never be a long-term process. In tuberculous bronchostenosis, we actually open it up and see if it's open. And if it is open, we leave it at that, because ideal is not to do any stent. If there is a collapse again, we try to put in a stent if possible. Post-surgical airway issues, again, in benign thing, and post-transplant are the other reasons, but we'll concentrate on malignancy here. Next, please. So this will be what Dr. Rajiv said. So in the picture, there is a total intrinsic, wherein there will be only debulking, whereas in the second and the third, there will be a role of stenting, because the airway is collapsed. So you'll have to place this stent to keep the airways open. Next. Or in a tracheoesophageal fistula, which this is a malignant esophageal fistula coming from the esophageal side. So these are the malignant reasons why we do a stent. Next. So how do you choose the best stent? The best stent is something that you do not place. This is a statement to say that you don't really put in a stent in a jiffy. You'll have to exhaust all the options and ensure that the patient earns for a stent, because once you put in a stent, then it is just a start of the problem. Ravi just briefly alluded to. Keep clicking, sir, so that we'll finish the whole thing. Can you just keep clicking, because it's, yeah. So when will you put in a silicone stent? In a context of malignancy, you can keep clicking, sir. In the context of malignancy, silicone is done only when there is a benign or a slow-growing malignancy, typically a thyroid tumor. So if you have a slow-growing tumor, but there is also significant weakening of airway and you want to support it, you put in a silicone stent. Why? Because it's easy to remove it if you feel like removing if there are any other problems. And also because a metal stent, the reason why you put in a metal stent is you think that the longevity of the patient is going to be only about 6 months. Because the stents are designed and these nitinol gets tired after that, we can have complications. So this is purely for a stipulated period of time, whereas a slower growing malignancy, the stent can outlive the purpose. So you might have problems because of complication of stent. So in a straight or a Y stent, you actually silicone can be straight or Y, and you use it predominantly for benign lesion. And if it is in the malignancy, it's a slow growing malignancy, you'll use technically a silicone. When do you use a metal? Metal is used when there is a malignancy, and in cases of transplant, we have uncovered metal stent. I mean, that is because, you know, in a metal can be covered by another silicon layer. Why do you do that? You do that because if there is a malignancy, it can grow in, because if there is a lot of area between the wires, this a tumor can grow in, so it serves no purpose, excepting in transplant where you want that you know, a little bit of growth so that it can cover a dehiscence. Only in that setting you use an uncovered metal stent. Rest of the time use a covered metallic stent only. So indications for metallic stents are invariably malignancy, post-transplant, and in some cases of TB bronchostenosis, when you cannot put in you cannot dilate enough for a silicone stent in place. So to you know, choosing the best stent, it depends on the indication. If it is a malignancy, if it is a fast-growing malignancy, you would rather use a metal stent. Next. So this is a silicone stent, and you can see that there are studs inside this silicone stent. This will help in preventing the migration, but still silicone stents can migrate. And next. This is a metal stent. We are showing a covered metal stent here. A covered metal stent is, this is a single woven nitinol, and it is covered by a PTFE or a silicone membrane. It's easy to deploy, difficult to take it out. Next. So metal stent, which is what I'm going to concentrate a little bit. There are different companies in India. You have Automed, you have Bona, you have Niti, you also have Aero Stent, and you have Boston Scientific, which is partially covered. Next. So usually a metal stent will come with this, you know, a pack which has all these information. So you have an information about what is the length of the stent, which will be in a 30 millimeter, 34 millimeter, 43 millimeter, which means the stent length is around 3 centimeter. Typically for a main bronchus, the left side you use the 3 centimeter, right side you use the 2 centimeter, and in trachea you can use up to 6 centimeter. It depends on the number of you know, cartilages you want to cover or the area you want to cover. Typically, when you put in a stent, you'll have to ensure that at least 1 centimeter on either side of the pathology is covered, so that the waist of the stent should have an area above and an area below, which is normal, so that the stent is covering or straddling on both sides. You also have a diameter of what the stent deployer is and all that. And these are very important to know what are the conduit you're going to use and how it is going to go in. Next, please. So how will you deploy it? In a self-expanding metal stent, is deployed with flexible bronchoscopy only is enough. It is deployed under vision ideally, though radiologists have also used it. It's technically easier, and also you're more sure when you have a bronchoscopic vision also. It is ideal to have a conduit, preferably a rigid bronchoscopy, but it can be done without rigid also. There are two ways in which it can be deployed. There can be a thread, which if you just pull it, the stent can open. It usually typically opens from distal to proximal. You also have a sheath which actually can be pulled using the deployer, and the stent opens from behind, I mean, from distal to proximal. The advantage of a metal stent is, even if you started opening it, if you want to you know, you want to adjust the position, you want to pull it a little more, you can actually do it. So this is easy to reposition. Even after it is fully deployed, you always deploy it a little farther, little distal, so that you can easily pull it. You can never push these stents. So it's very important that you place the stent initially, deploy the stent a little distally, and then pull it up. Next. And removal is, when do you remove a metal stent? Next, please. You can keep pressing, please. Just keep pressing and fill the whole thing. So when you remove a metal stent when you have someone else placed for a reason which has actually got better, or you know, is not required, or is not placed properly, or when placed when diagnosis was not known, initially thought of as a malignancy and subsequently it was not malignancy, or when you want to remove it, like in a tuberculous bronchostenosis. These are in benign condition. Next. In malignant condition, when do you remove? When the patient has outlived the stent has fractured, a stent stopped the purpose, so you'll have to remove it. And or the stent has been outsmarted by the disease, or new complication related to the stent, like a TEF beyond the stent. Next, I think the complication was also addressed, you know, by Dr. Ravindra Mehta. And this video will tell you how metal stent is removed. Can you play the video on, please? So this patient was. put on a metal stent, and we had to remove the metal stent. You can see all the complications that Ravi mentioned also. There is a biofilm, the stent looks ugly, and the stent was put for a fistula, but you can see that the fistula, which is an esophageal malignancy, the fistula is actually expanded. And what you see on both sides of the carina and what you see on the 6 o'clock position is the stent actually digging deep and burrowing the the damaged airway, and you can see that there is a huge fistula now. So you have to remove it and put in a Y stent. Next, please. And this shows how a stent can be removed. The metal stent has to be removed with rigid only. So you can put in without any rigid bronchoscopy. You can use put it with a flexible bronchoscopy. But for a removal, whenever there is a complication, you will need to have rigid scales. Next slide. And this is how a metal Y comes out. There is a right wing, which is a right limb, which is a shorter limb, and there is a left limb, which is a longer limb. And you'll have to, ensure that the right goes into the right and the left goes into the left. For that, you'll need to have fluoro also. So metal Y is a difficult stent to put in. And I think Ravi showed a video of that also. Next slide. And I think complications has already been dealt with. There are immediate complications, and then there are long-term complications. Migration, non-deployment, proximal deployments are immediate. Intermediate is when there is a granulation or a fatigue or a fracture of the stent or a tracheoesophageal fistula, and a long-term is difficulty in taking the stent out and tracheal cartilage damage. Next slide, please. And this is one case where there is a stent fracture. Can you click on the video? You can see that the stent, which is supposed to be, completely covering, you can see on the posterior, it's just lifted up. That is because the stent was fatigued and it got into a fracture. And you can see there are two segments on his right hemisphere and the left hemisphere. And the patient had a significant cough after the stent fracture developed. The fracture of the stent typically happens after a few months of stent. And this is the reason why you have to take it out. Next slide, please. Next slide. I think we've shown this again. We don't need to go through. And in silicone stents, next slide. It's either straight or Y. It's always deployed through rigid bronchoscopy. So for silicone stents, you'll need a rigid bronchoscopy skills. And anything more than 13 size, which means in trachea, you'll need to have a bigger size. It'll be 14 or 15 or 16 or up to 18. We don't use 18 though. 16 or 15 is a tracheal thing for adult. It requires a size 14 rigid barrel. See, 14 mm barrel has to be put in, and even that is not enough. See, silicon, unlike a self-expanding metallic stent, it can only be folded. Despite folding it, you can, you need a large barrel for you to put even that folded stent inside. And so you'll need to have certain applicators, and the deployment is usually blind. The stent length can be customized on the table, and that is the advantage of silicone stent. So you have a smaller lesion, you can actually customize the stent, you can reduce the size, whereas in metal stent, it comes in a certain dimension that you can't really alter. Experience and eyeballing are the best way to predict the diameter. Repositioning and retrieving is easily done with the rigid skills and appropriate instrument. And this is a big advantage for a silicone stent. Next. And a silicone Y, again, in a carinal lesions, which is a long-standing thing like a slow-growing tumor like adenoid cystic, the deployment can be tricky and need to customize the right limb to ensure that the upper lobe doesn't get cut off, and deployment again is blind. And you'll need to have a good amount of experience to get into silicone Y stent. Next. And again, the complications has been dealt with. Keep clicking it. Just to reiterate, there can be an immediate complication. The most important complication, especially in the straight stent, keep clicking, sir, is the migration. There can be inability to deploy, which is a technical issue, and probably by experience, it should be all right. Sizing issue is usually an important thing. If the stent opens immediately, then that means it's undersized. The stent has to open with difficulty, only then it will not come out. Migration is a huge issue. Intermittently, there will be an intermediate thing, there will be a halitosis and thick secretions. It has to be maintained properly, and you need to have a follow protocol for that. An intractable cough, because it's a foreign body, any stent can cause this. Long term can be granulation. and a biofilm which can cause secondary infection. So these are the reasons why you would also remove it. Next slide. These are one of the stent that was removed. The good thing is it has no mucosal changes, so it's ideal for long term, and it's usually a bridge for surgery. So because when a stent is done, it doesn't affect the mucosa. The mucosa remains pristine. So even if the surgeon wants to do any procedure, once you remove it, immediately the airway is good enough for the next procedure. Whereas a metal stent, especially the uncovered ends, can actually dig into the mucosa, cause irreversible changes, and at times what would have been a surgical things, once you put in a metal stent, especially the uncovered portion, if it is significant, it might change a operable lesion into a non-operable lesion. So you'll need to be very careful and responsible whenever you choose the stent. Next slide. You'll need to know all the advantages and disadvantages. To summarize, stents are an important aspect of IP. Stents are life-saving in emergency situations. You have to choose wisely between metal and silicone. A good rule of thumb is for malignancy and aggressive lesions, metal is good. When you suspect a slow growing, or when you suspect that you are in a situation where you might have to remove it, typically is when there is an extensive compression because of a lymphoma, which is compressing it, and you know that with treatment it's going to get better, drop a silicone stent because it's easy to remove it after that. Always comes at a cost, and always remember the initial thrill is short-lived. Have to face the short and long-term consequences. Once you stent a patient, you're literally married to that patient. Patient can come in with the breathlessness, with a clogged stent at 6 p.m. at Saturday, and you'll have to put everything together, and you'll have to open the suite, and so it's a 24/7 thing. So I think that these are just a few points to know about stent, and so I'll be happy to take any questions regarding this. Thank you, Rajiv, and